So let's get started with today's clinical topic. Our speaker today is Dr. Ben Miraglia. He received his dental degree from State University of New York at Buffalo School of Dental Medicine, and he's been practicing general dentistry for over 30 years in Mount Kisco, New York, including over 20 years of clear aligner experience. He's currently the Vice President of GP Clinical Education with Candid Pro. He spoke at our aesthetic symposium last week, did a great job, and I'm delighted to bring back Dr. Ben Miraglia. It's all yours, sir.
All right. Good morning, everybody. Just making sure my title slide popped up there. Did I get that right?
That's perfect.
All right, here we go. So comprehensive care with the clear aligner foundation. This is a part two. We had done a little intro into what we're up to. And then Dr. Park just gave me a little introduction with the credentials. Let's get started. We're going to use 3 cases to kind of build this out. And the first case will be comprehensive care with the clear aligner as a foundation. We're talking about restorative dentistry as well. And so we're going to meet a patient who has a chief complaint of, I'm embarrassed to smile, I'm ready to fix my teeth. And she has not been to the dentist in about 2 decades. So we have a lot of issues going on. We're going to find some teeth hopeless and several teeth we can fix and repair. And then, of course, we're going to find that lower anterior crowding. So, you know, we always approach the case comprehensive care, which means we have to look at perio, endo, restorative. There'll be a range of hopeless to, restorable with good prognosis in here. So we've got a nice range in here. But one of the things that we might slip through the cracks is the alignment of the teeth. And so even though I know these photos look horrific and it's a big case, we have a lot to do here, but we have to take a step at a time. And we do want to think about the ortho component because we're going to have a lot of restorative happening here. And it would be really nice if we could have well-aligned teeth to do it. And so the lower anterior teeth are very crowded, and that does compromise the perio, etc. So we'd like to have the ortho component as part of our treatment plan. And a case like this is going to come with x-rays that, again, show what you see on the outside, but on the inside. So we have a lot of neglect over the years, a lot of deterioration over the years, and we are going to lose a bunch of teeth. Basically, the posterior segment is going to have a lot of loss. We have a bunch of hopeless teeth in there. The upper anterior segment can be saved. We're going to be getting crowns in there, but we are going to think about our pathway to the alignment of the lower anterior teeth because we'd like to spread those out, develop a little bit more of a broad arch form, and then have the beautiful alignment of the lower teeth kind of support and dictate how we restore those upper anterior teeth. It'll change how the restorative gets done. So immediately we get into temps because we have a lot of fires to put out. So we can get temporaries in there immediately. So the upper temps will be placed, and of course through hygiene. So this is a patient who will go through several rounds of scaling and root planing and instruction. This happens to be right after one of the last scalings, so you can still see the little red marks around the gum line, but the tissue's improving from a set of temps. We've got decay removal out of there. We've got the plaque and calculus removed. We still have all those little posterior roots in there. We're planning for extraction, grafting, implant placement for the posterior segment. But when the temps go in, you can kind of see what we've got. Okay, we've got a nice temporary in there. Tooth number 12 has a horrific root canal result with a post. Even looks like a double post. This tooth was hopeless. We know we're going to lose it. We're keeping it in the temps because we're going to work our way through the alignment of the lower anterior teeth. Eventually, that tooth number 12 has to go, and we'll basically include that in the implant reconstruction. So once we get the temps in place, we have basically removed all of the decay on teeth that we're going to save. Then, of course, the hygiene has removed all of the plaque and calculus around the teeth, and we get a little bit of initial healing. So now we would consider this decay-free except for the roots that will be fully extracted from the posterior teeth. It's time for the aligners. So basically, once we're decay-free and have our perio stable and under control, it's time to move those teeth. And if we're going to move the lower teeth to spread them out, we need to move the upper as well. So even though we placed temps on the upper, we're going to allow the software to move the teeth. Now, the lower teeth are spreading out nicely from premolar to premolar, kind of putting them where they belong. The upper teeth are going to have to cooperate with the lower, meaning expand also. So what we do in the video game here is we see the teeth moving because we've allowed them to. When we go back to the mouth, we'll just make little sections in the temporary. So we can section the temporary to allow the teeth there to flow as well because we're going to be graduating to final crowns when we're all done. It's okay to have the temps moving. So we just have to have separations where we know we need movement. So nice and smooth. We're basically going to start moving those teeth, and here we go. Whoops, too fast. So what we had before in the upper was the kind of all of the decay in the original teeth and the old crown on that number 12 there. But we started to make sections in the temps to allow the teeth to move. So now the patient's going to have worn aligners to get to this point, and the lower will be fully resolved. So now while we have the lower fully resolved, we've placed the lingual bar there. Now, I don't do that a lot. I do that on occasion. This particular patient thought that she would be a very poor candidate with the overnight retainers and might slip up, forget to wear them, have her teeth shift back. So we said, we agree with you. If you believe that you're not going to wear your retainers well, we should put the lower lingual bar. Well, let's put a fixed retainer on there to protect those teeth. So we put this here. We still make the clear retainer overnight to use as well, but at least I have a safety net should she stop wearing it. So now the lower arch is well aligned. The gum tissue looks amazing. She's taking better care of her teeth. We've got a temporary, setup in there, which we're going to be changing out. And now this is where we are kind of post temporaries being placed, alignment of the teeth, and whitening gel. So now the patient has had basically scalings at the beginning, temporaries across teeth that need crowns, and then clear aligners. So now we've got our Glidewell clear aligners finished. We've got our teeth well aligned, and now it's going to be time to kind of move along with our final restorations. Now, the patient at the beginning was very self-conscious, would not smile, kept her lips in an awkward position, didn't want to really share her teeth very much. With the temporaries in, she starts to smile a little bit. She's doesn't have a natural good smile yet. She still is a bit self-conscious about her teeth smiling where she is. But now at least when you ask her to smile, she'll show you some teeth. So we have temporaries in here, and we just have basically her heading in the right direction where one day she'll probably give us a very nice smile. So now we can swap out the upper temporaries for crowns. We're using the Bruxier aesthetic crowns. So the Bruxier aesthetic crowns, numbers 5 through 11, and then of course the rest of the posterior are going to end up being extractions grafted for the full implant workup. So we've got our Bruxier crowns here. And again, on the lower, we just have the single Bruxier crown. We have our lingual bar in place. So the lower has basically well-aligned teeth with a beautiful remodeling the gingival architect now. And now the patient can work her way towards dental hygiene. And here we are with our set of Bruxier crowns against well-aligned lower teeth that have full gingival remodeling. So the patient's a little better home. We have a lot of stability here. With all of this stability, we basically now turn attention to the posterior teeth, meaning there's going to be extractions, grafting, and we are going to be using the Hahn implant system here. But at this point, we've gotten our anterior segment kind of more to premolar also. We can transition her to our Glidewell flexible partials. So to give her something in the posterior to have a little bit of support and start heading towards, okay, final arch width and alignment, we can make flexible partials. So we have an upper in place, and then we have a lower in place. And so now she basically has something she can kind of land together on and have a full bite. And it's kind of a good test or starting point of where we're finally headed. The flexible partials are probably a fraction narrow in a couple of spots. We might adjust some of those teeth when we go through our implant placement. But this case is now set up for final ridge grafting as well as the Hahn implant system. So what we're looking at here is kind of like a stage. Stage 1 was decay removal with temporaries and hygiene, getting everything scaled and root planed. Stage 2 was clear aligners. We got to get the Glidewell aligners in there, get the lower and upper kind of widened and organized. And then stage 3, final crowns across the upper anterior teeth. And stage 4 is going to be the posterior implant reconstruction. So this is where we are now. We have a completely different mouth. So we have gone from what was really completely deteriorated in every dimension, whether it was the restorative, ortho, perio, all the way to multiple hopeless teeth, to a very stable mouth. And the clear aligner have a nice role in it in getting the arches lined up nicely and setting the tone for beautiful gingival architecture, healthy shallow pocketing, a beautiful bite, and the rest of the restorations. So we're seeing this case at like a stage 3 completion, and the Hahn implant system is next. That'll be over the next few months. This will be a case as we finish the post update and share the finals. Now, part of our agenda today was to talk about TMD and airway patients because some of this airway is the most popular in
Dr.
dentistry today.
Miraglia,
Everybody's looking at airway and saying airway and treating airway. Yes.
do you mind turning your camera off? You have a
Hello?
little, can you hear me? You have a little bit of low
Yep.
bandwidth, so do you mind turning your camera off? I think it might help. It's just
I
you're
can
getting a
turn my
little
camera
steady.
off. That's the stop video.
Yeah, let's try that. Thank you. Sorry to interrupt you.
Okay. No problem. No problem. Thanks for the heads up.
Yeah, that's better. I can hear you already better. Thank you.
All right. Terrific. Okay, so we've got the TMD and airway patients to consider because you can't be in a dental practice without hearing about TMD symptoms and or airway type of stuff. Whether you're doing it or referring it, that's fine, but we can pay attention to it because there might be an opportunity with our clear aligner system here at Glidewell to offer help for some of these patients. So first, we just review a little bit of the sleep disorder breathing OSA research. And there are a lot of quotes. There are a lot of quotes in the research about narrow about narrow V-shaped arches. So here's one of them. The class 2 malocclusion was significantly more common in the OSA group. The V palatal shape is a frequent finding in the OSA group. So patients with obstructive sleep apnea tend to have a V palatal shape. Snoring is associated with straight profiles, V-shaped palatal morphology, increased neck circumference, and here come a bunch of long words for underdeveloped, but decreased upper arch length and decreased interfirst upper premolar distance. So this is about crowding, decreased arch length and narrower. This is that crowded malocclusion. A crowded malocclusion usually has a problem with length and width. So all of a sudden we have a narrow arch showing up in the research. Patients with OSA had significantly narrower maxillary and mandibular arch widths when compared to control groups. These findings support the notion that a narrow maxilla or mandible may lead to airway obstruction because of inadequate space for the tongue. Thus, when the space in the oral cavity is inadequate, it's possible that a normal-sized tongue can gravitate to the back of the oral pharynx. So it seems like common sense. If your teeth are crowded, they're closer to the tongue. When your teeth are crowded and closer to the tongue, your tongue has less room. When you close your mouth, the tongue only has one way to go. The teeth are a wall at the front and the sides. So crowded teeth, when they're closed together, force a tongue backwards. So that can't help us out when we're breathing. Another quote, a narrow maxilla with a high arched palate characterizes a phenotype of patients with obstructive sleep apnea. So we have basically the word phenotype to look at, it just means the look. That's the look of. So phenotype is your look. A narrow maxilla with a high arched palate is the look of patients with OSA. And the following sentence kind of clears it up. This is associated with increased nasal airflow resistance and posterior displacement of the tongue. The narrow arch delivers the posterior displacement of the tongue. So when we think about treatment options, there are multiple treatment options for patients in the kind of TMD airway space. And it's a long list, but it does involve informed consent. You can get a CPAP. If a patient has a sleep study and it says they have obstructive sleep apnea, they should get a CPAP as their first choice until they can work through other options. You probably want to be breathing better and sooner, as soon as possible. You can think about MMA surgery, very aggressive, but it does work. You can have an MMA, which is maxillomandibular advancement surgery, bring the jaws forward, open up the airway space for yourself. You can breathe better that way. Inspire is out there. It's basically a stimulus. It's a device that gets implanted much like a pacemaker would, but it gets wired to the tongue. And when your tongue falls back, it kind of gives it a stimulus to move it forward. So it makes the muscle move your tongue forward. That's a possibility. You can get involved with surgically assisted expansion. So there, MARPE, SARPE, all of these things that are out there to use surgical assistance for your expansion technique. Mandibular advancement devices exist. You can make mandibular advancement devices to hold the lower jaw forward. And then, of course, the lower jaw forward, tongue forward, better breathing. You could look at removable expansion or growth appliances. And so for adults, it's in the non-surgical category. It's just very slow. So if your adult patient is willing to have a very slow treatment pathway, you can talk about removable expansion or growth appliances, which we would consider auxiliary techniques because last but not least, we have clear aligners, which can increase tongue space. So clear aligners to solve crowding would be posterior teeth expanded, anterior teeth proclined. If you're moving the teeth away from the tongue, you're solving crowding, but you give your tongue more space. And with every millimeter the tongue gets, it would appreciate it, but it also has the ability then to take that space over and be more forward and higher. So it's nice to give the tongue more space. Not everybody agrees with a CPAP. We know that's got a low compliance rate. Not all our patients want surgeries, whether it's MMA surgery or Inspire or surgically assisted expansion. Mandibular advancements, they work for a lot of patients. They don't for others. They can change your bite and have other risks associated with them. But then you get down to the most conservative. So as we're working the way down, the bottom of the list is just a simple pathway of most conservative approach to see if it helps your patient. Now, the important part here is recognizing that we do not treat OSA. I don't treat OSA and I don't treat any other kind of sleeping diagnosis or like snoring or even upper airway resistance. Basically, I'm treating what I'm diagnosing, which is malocclusion. So I'm diagnosing malocclusion. I am diagnosing in the arch form, arch width, and inclination category. When you're treating what you're diagnosing, well, there's a fair chance that the collapsed arches with the crowded teeth take away your tongue space. So downstream, you have poor breathing. What level of breathing, it remains to be found out by testing, but you're just treating the underdeveloped jaws or the malocclusion. Work your teeth wider and forward, move them away from the tongue. And then you can find out, well, what difference did that make? Did that improve my patient or not? And I think you'll find most of the time you're going to have improvement because giving the tongue more space is a very big deal as far as the breathing goes. So we'd like to explore a couple of auxiliary techniques that are involved with clear aligners, where the clear aligner would be a stage 2. So we'll take a look at a case where we have an adult with a removable expander first, followed by the Glidewell clear aligners, and then we'll take a look at a patient who has a fixed expander first, followed by the Glidewell clear aligners. And then you have your clear aligners being utilized as a stage 2 with an auxiliary technique to get us in a position where we might be able to help our patient. So I found this nice quote in Constant Change, Mr. Glidewell's book. The human body, for example, is perfectly engineered to function at its optimal level. All of the organs work separately and in unison for the greater well-being and efficiency of the body as a whole. This collaboration for the success of the whole is not unlike the way Glidewell Laboratories operates. Each department works for the success of the entire company. And of course, since we're talking about clear aligners and teeth, we're referring to the mouth, because imagine if the mouth is malfunctioning. Well, if your oral cavity is unhealthy, it turns out the rest of you is unhealthy, and we're totally connected and related. Of course, the mouth is connected to the body. So we have this opportunity to help the mouth and see what happens downstream. So we'll take a look at a case here, an adult. Now, she gets to our office with her chief complaint being TMD now. And what you're looking at these two photographs, one from 2011, which, she brings in to show us in 2011, this is what my smile looked like. But in 2017, she's showing us a photograph after she has had Invisalign. So she did have Invisalign from 2016 to 2017. And the problem is that up to 2016, she's never had any type of TMD complaint, no facial pain or fatigue or trouble in her muscles, no joint issues. She basically has been free of any type of TMD symptom or complaint for her entire history. But from 16 to 17, she notices using those aligners, all of a sudden, she started noticing her facial pain, the jaw pain, and it remains to this day. Of course, in 2017, she notices a difference in her smile. She believes it's more narrow. I would agree, it's more narrow. We ask questions, did you have polishing between your teeth? Yes, I did. So, of course, there was IPR used for her case. She had a lot of polishing between her teeth to make the front teeth straight. But now she's in a position where the TMD was brought on during that treatment, and she's not about her words. Then you have to interpret and maybe a different. So here she is, and it looked really fine because you have straight and they come together reasonably well. But what you really is someone who's too narrow and the lower jaw is trapped. And with the lower jaw being trapped, all of a sudden, we recognize that her retractive orthodontic technique she just went through has brought on the TMD symptoms. So here she is too narrow with four jaw trapped with straight teeth. So we're going to be looking for a wider and forward pathway. So we put her in room expand, and this takes a while in an adult. You're looking at 6 millimeters of upper and lower growth, but it does take almost 15 months to do it. So a very slow pattern of wearing and then removing these all day long to create a site pressure and tension can give you not growth. And so when you're getting all this growth, you're basically developing a better foundation. So we're going to make her bigger and then coordinate the teeth. So we get to this point. She's now 35 years old. Because of the TMD complaint, we're going to call her a severe malocclusion, even though she has no crowding. but we've taken her through removable expansion devices to get to here. So the removable expander is the 11-month process. Now we're going to go through 15 months of doing the clear aligners. So now that we've got the teeth kind of all the way out where we want them to be, it turns out at this point she has no TMD symptoms, but we want her wider and forward. So we're going to move the teeth even a little bit wider and give the upper teeth a significant amount of proclum to release that trapped lower jaw. So we're going to through an aligner set now things even wider and a little bit more forward on the upper, giving her clearance for the lower jaw to come forward. The track jaws, she moves through the 16 aligners perfectly. Going through the first 16 is wonderful. That's only 8 months. We're going to do another dozen aligners. So 16 and 12, 2 rounds to get the entirety of the width we want, as well as the forward movement of the upper teeth to clear that lower jaw pathway forward. And basically what we do is we've taken her through the removable expanders first, foundation approach, and the clear aligners, and we've consolidated all of that space at the laterals. But what you're looking at is a 10 millimeter width change. So her beginning, she had a 30 millimeter transverse measurement, and a 30 millimeter transverse measurement, just to put that in perspective, is the low number that you could have to be considered normal when you're 4 years old. So a 4-year-old should have 30 millimeters between A and J. Excuse me. A 4-year-old should have 30 millimeters between A and J. She's got 30 millimeters at her age of 35, which is a terrible narrow arch form and width. We need to be at 40 for health. So we get her the first 6 or 7 millimeters with the removable expanders. Then we get the last 3 or 4 with the clear aligners. Now we've got this beautifully well-developed arch, and the lower follows it. Here we hit a little bit of the space behind the premolars. But instead of the lower molars being collapsed towards the tongue, we now have a wide open arch, and all of this adds up to a tremendous amount of tongue space. So if we look at the upper arch, that's a much bigger chamber for the tongue. The lower arch is a much bigger chamber for the tongue. And now her bite, while it looks like it connects nicely, it's just 10 millimeters wider. So this is now representing a 30 millimeter to 40 millimeter, a 10 millimeter wider bite, which comes with, again, from the removable expanders, the bone growth first, and then the clear aligners second to get the teeth fully coordinated to come together again. All of this adds up to a patient that has absolutely no TMD symptoms, again, like her past. And then you can appreciate it in the bite and the smile. All of a sudden, she went from 2011, where she had a narrow smile, going through a retractive IPR heavy technique that was Invisalign for 1 year from 16 to 17, ended up with a more narrow smile, and then as well a TMD list that was uncomfortable. Then afterwards, we have a patient who has the 40 millimeter transverse measurement, a beautiful arch forming with an incredible bite, a little space hidden at the laterals and the premolars, which to this day we still haven't restored because she's happy and fine, doesn't need it. And we do restore those teeth for patients who decide, I don't like that space. That's totally up to you and the patient. You talk it through. We either use bonding or veneers or other stuff, but here we've had no restorations. So we go through the removable expansion, then we go through the clear aligners. And then if you want to do a little restorative, you can. You can always use whitening gel in there to keep that patient's teeth shade down nicely. So you get a fantastically broad white smile that shows all teeth full display all the way back, and that patient has no TMD symptoms. So basically an expansive kind of growth and development type of technique, wider and forward, is what gives your lower jaw the freedom to come forward, and then giving you proper position of your musculature, condyle, discs, everything settles right back to where it belongs, and we get our comfortable patient back. The opposite is true. A retractive technique, heavy IPR, narrow arches maintained, plus front teeth backwards is going to give you a retractive technique. You probably would recognize TMD symptoms popping in there occasionally. It's one of the risk factors for TMD is the narrow trapped lower jaw. So you want to be careful to be going wider and forward. Now the final case is a little bit different. We're going to use, again, auxiliaries because we have this opportunity to use aligners plus. So we're going to use fixed expanders for this patient. We meet this patient at age 14 and a half. And this patient at 14 and a half has a diagnosis of obstructive sleep apnea already, has a diagnosis of insomnia, narcolepsy, anxiety, depression, headaches, asthma, TMD. Whoops, too fast. So this is an interesting consultation because I don't treat most of that list. You know, at best I treat TMD, but I really don't. I treat malocclusion. And so I treat malocclusion by growth and development. We're going wider and forward. And most of the time, the TMD symptoms are going to decrease and then disappear by the end of treatment. So TMD would be the only loose one here that you could consider. Maybe I'm treating it, but I technically treat malocclusion. The rest of the list I don't treat. So we don't treat these things. However, we do recognize in a diagnosis that the patient is narrow and trapped and basically has underdeveloped jaws that we'd like to treat. So we have malocclusion. Now, she does have straight teeth because she did have braces for 2 years. Somebody gave her braces from 12 to 14. So 2 years in braces gave her straight teeth, but braces don't give you widening of the jaws and any type of forward movement. So we have basically a 2-year bracket and wire technique that is retractive, as braces are mostly retractive. We end up with straight teeth, of course, with braces, but that's all you get from braces is straight teeth temporarily. So in the end, what we really need to know is about this picture here. How much room does her tongue actually have? This is an interesting picture to take a look at because when you're looking at this picture isn't quite clear on the previous one. When you're looking at this picture here, you get to see, well, of course, I have a patient that has a nice lined up set of teeth, but the most important part isn't what this looks like, it's what this looks like. Because when you close your mouth, you just have to consider, where is your tongue? Where is her tongue when she closes her mouth? The previous picture, we don't get to see or really comprehend where is her tongue. If I show this photo and I ask, where's the tongue? You say, well, it's right behind the teeth. Of course, it's right in there. But then you look at this picture and you recognize, oh, I start to get it now. She does have a perfectly normal sized tongue as every other human being. So the tongue is the right size. It's the jaws that are too small. So we have undersized foundation and of course straight teeth. But now when this patient closes her mouth, her tongue has nowhere to go but backwards. Just like the research quotes, narrow gives you the posterior displacement of the tongue. She already has scalloping. The scallops on the side of the tongue are an indication that, of course, when the mouth is closed, the tongue is pressing into the teeth to let the air go behind it. That's why the tongue is scalloped. It doesn't have any room. And of course, you're going to be pushing it forward to let the air go behind it. So this makes it a big struggle to breathe through your nose. It's hard to have your mouth closed when your tongue is positioned that far back. She does have a bit of a lingual frenum attachment there. Could be a little bit tight. Will involve a myofunctional therapist to maybe take a look, do some exercises, figure out if that's too tight. Because if we're going to build a home for this tongue, we want it to be able to pull it in. So basically, you consider, I got this tongue here that you might consider a Ferrari. And if you have a Ferrari, you would want to build the right size garage. If we build the right size garage, well, the Ferrari needs to be able to pull all the way into it. And sometimes the frenum is a leash that keeps the tongue back a little bit. So we're going to want to iron that out. And it turns out this one is a mild to moderate type of attachment. So a little bit of tongue tie going on here too. So now as far as the transverse measurement goes, she measures 29 millimeters. Now 29 millimeters between 3 and 14, that's an unacceptable number when you're 4 years old between A and J. So between A and J, we'd like to be 30 at a minimum for kind of considering normal good growth and development of the jaws. She measures 29 at age 14, and we know that will not be a good number for her tongue space, but also for her nasal cavity. And so the vault, the more narrow the jaws are, the higher the vault is. The more narrow the jaws, the higher the vault. The higher the vault, well, the vault or palate is also the floor of the nose. And when the floor of the nose is higher, we lose space in our nasal cavity. It turns out the maxilla also makes up the lateral walls of the nasal cavity. So when the maxilla is narrow, the nasal cavity is narrow. So basically, when you're looking at a narrow vaulted maxilla, you also have a nasal cavity that is narrower and has a higher floor or ceiling, whichever we're going to call it. But basically, you have a smaller area to breathe through. The nasal chamber is compromised. And of course, the rest of the airway, nasopharynx, oropharynx, laryngopharynx, all compromised by there's no room for the tongue. It would have to be backwards. So we're at 29 millimeters. We need to get a whole lot bigger. And the lower teeth have her lingual bar from her 2 years of braces. So braces delivered the straight teeth. It maintained the arch width, which is they're famous for doing that. So basically you have a bracket and wire technique that did not offer her wider and forward, just straight teeth temporarily. Meanwhile, you have a child with a dozen symptoms that she's been struggling with since she's 3 years old. When you take a full history, you learn about age 3. She had digestive issues. She couldn't sleep through the night. She ended up with an endoscopy by age 6 to learn about what's going on inside. Nothing to find there. But meanwhile, she does have a sleep study to show the numbers. Now, the respiratory disturbance index of 65, that's a lot. And then apnea, hypopnea, AHI 47, 9.3 per hour, 6.7. These are big numbers, even if you don't know what it means. The important part is I didn't say she had OSA without having a sleep study. She does have mild to moderate obstructive sleep apnea, characterized by the elevated indices. restless sleeping, snoring, but she also has a consideration for narcolepsy, which there's a test for that. It's called a multiple sleep latency test. So a multiple sleep latency test is you're given 4 chances to take a nap. And in a 20 to 30 minute window, number one, can you fall asleep in most of them? Can you reach REM in most of them? If you meet those criteria, you have a diagnosis of narcolepsy. Lauren had 4 chances to nap and slept in all 4. So she falls asleep in 9 minutes. In 3 of the 4 naps, she enters REM. You're not supposed to enter REM in 20 minutes. So basically, she falls asleep in 4 of these little half-hour sessions in 9 minutes, and in 3 out of 4, she reaches REM. And a sleep cycle is much different than this. This is a fragmented sleep cycle, basically, where she reaches the category of narcolepsy, and it ends up with notes to school to give her more time. Once again, in assessment, Lauren has at least 1 and in all likelihood 2 distinct organic sleep disturbances, accounting for her excess daytime sleepiness, occasional poor school performances, lateness, and absences. I would ask her school and teachers to be understanding until this situation gets rectified in the next number of months. This is the pediatric pulmonology letter. I have to write a letter. We're basically going to be treating her malocclusion, her underdeveloped jaws. And then once we do that, we'll see, how this all goes. So basically, we're going to get her into like a liner plus. So we are going to be using our Glidewell clear liners in stage 2. Her first stage is going to be fixed expanders. So she's going to get an upper and lower fixed expander for 9 months. And over a very slow amount of time, we're going to be getting her a chunk of millimeters, which you'll see measurements in a second. So this is the day of removal. So fixed expanders go in. We use them for 9 months slowly to make this change. We take her from 29 millimeters to 38. Now, 29 to 38 gives a big change in the width, but the bigger change is the rotation of the vault down. So now she's not as shallow. So now basically we're more shallow, we're less vaulted. So basically now what's happened is the roof of the mouth or palate has come towards us as this maxilla has been expanded generously. So we get 9 millimeters of expansion, but during that expansion, the roof of the mouth floor of the nose is coming down towards us. So we're now shallow. That starts opening up the nasal chamber. Expanding the maxilla takes the lateral walls of the maxilla wider. So now the nasal cavity is bigger. We've moved the lateral walls of the nasal chamber wider by expanding the maxilla. And of course, the floor has now come lower, or the ceiling has now come lower towards us. So you start opening up the nasal cavity. So don't forget about the maxilla. It not only makes up the entire lateral wall of the nasal chamber, it makes up a quarter of the orbit as well. So you're doing a wonderful job here opening up the nasal chamber. The lower has to follow. If you're going to do 9 millimeters of fixed expander on top, you're going to need it on the bottom to keep the bite together. So the lower gets a fixed expander as well for 9 millimeters to make sure that's even. This is the difference between the start and finish of the expander technique. So we're using fixed expanders nice and slow. And the difference here is that you've got no attention to the teeth yet. You've only had the fixed expanders in, bigger maxilla, bigger mandible, and then that starts to change the child. So with a bigger maxilla and a bigger mandible, all of a sudden now we have the ability to breathe well. So she can now breathe through her nose, and breathing through the nose nicely helps her to sleep better. So the child on the left side of the screen at 3 years old couldn't sleep through the night. She was basically waking up every 2 hours or so, and the parents don't recall her ever sleeping through the night. So we're talking about a dozen years almost of sleeping with waking up every 2 hours. Now we're 9 months into our process here. We've used our fixed expanders, and she starts sleeping through the night. And as you start sleeping through the night, you start to heal. So now you can see it in her eyes. The left side of the screen is a very unhealthy human being, and the right side of the screen is a human being who is already healing. So in just the first 9 months, we have a reduction of all of her symptoms, but now it's going to be time for clear aligners. Here's what she looks like when she has a bigger maxilla and a bigger mandible, with, of course, the teeth kind of spreading out a little bit. We've got better breathing. We've got our foundation right. So we're looking at a foundation first, teeth second approach. We're going to take the expanders off. We're going to scan for our Glidewell aligners. We're going to make in-office 040 S6 retainers to be worn full-time until the aligners show up in about 3 weeks. We are going to send her to a myofunctional therapist who determines that the tongue and the upper lip were tight. So she'll have revisions, tongue tie and upper lip tie released by Dr. Scott Siegel in New York City. In the end of this, we'll use clear retainers. So part 2 is the aligners. So after the fixed expanders on the left, we now use our aligners to widen the arch more. We started out after the expanders, we were at 38 millimeters between 3 and 14. Now we're up to 41. So now we're at 41 millimeters between 3 and 14, full coordinated arch form, beautiful space for the tongue. And the lower is going to that, so the lower has to get a little bit wider. So now we've got the lower aligners giving that extra 3 millimeters. Well, now all of a sudden her tongue is going to fit in that space. And we end up going from after the expanders to after the tooth alignment, plus another year later, we just get to have a senior year picture. So senior year of high school, she gets her photo taken. We get a copy of it. Of course, you can see now, a beautiful broad, wide smile. But the difference in this child now is that she has absolutely no symptoms. So we're going to review her history start to finish. At the beginning, we met her. She was 29 millimeters in between 3 and 14. We finished her at 41. Again, the first half of the treatment was fixed expanders. We would call those auxiliary techniques. The second half of the treatment are the clear aligners to then finish coordinating the teeth. Foundation first, teeth second. 41 millimeter transverse measurement is a beautiful space for the tongue, as well as a beautiful distance for good occlusion. And the lower has to follow it. So the lower teeth are fully broadened and upright. Again, bigger mandible first, coordinate the teeth second. And then we get to this bite here. So before she did have straight teeth, however, she had 29 millimeters and couldn't breathe and had a dozen symptoms she struggled with for a decade. On the right side of the screen, we have a bigger maxilla, a bigger mandible, well-coordinated teeth, and a beautiful bite. But on the right side of the screen, we have a child that has no symptoms whatsoever. 0 symptoms also means 0 medications. So the beginning picture of a 14-and-a-half-year-old coming in, and then, of course, at age 17, when you've treated her and then had a year past, you get to the point where child without any medication, she's not treated in any direction that we saw at the beginning list. And then, of course, you have unhealthy to healthy is the Mr. Gladwell, if the oral cavity is failing you, your whole body downstream might fail you. It turns out most of that symptom list that she had is related to poor breathing and sleeping. Our transition of growing the oral cavity, meaning let's use fixed expanders first, followed by clear aligners second, we get a full foundation and then coordinated teeth in there. And last but not least, you go ahead and you take your sleep testing to prove it, and they're all zeros. So those of you who know how to read this, see all the zeros in here. And then, of course, you can see how the total is 0.4. So 0.4 is the number of events per hour, or less than 1, you don't have OSA. So when you get a bunch of zeros and you have a 0.4, your sleep physician will tell you do not have obstructive sleep apnea. The note going into this at age 16 was the 16-year-old female having anxiety, depression, ADHD, diagnosed with moderate OSA and narcolepsy, had morning headaches, daytime somnolence, had a CPAP. She was a failed CPAP user. They had given her a CPAP at age 10 to try to help her. It failed. And sure enough, she's back in post lip and tongue tie removal, revision and palatal expansion to see if she has any symptoms. So she does not have the OSA, and she does not have narcolepsy because given the 4 chances to nap, she can no longer take a nap. She can't fall asleep during the day because she gets a full sleep study done. She gets a full sleep cycle all night long, repeated 3 or 4 times. Beautiful sleep at night, no napping during the day, no narcolepsy. Get a note from the family. Hi, Dr. Miraglia, I hope all is well. Attached, please find the results of Lauren's recent sleep study. I included the ones from 3 years ago. Very interesting how she no longer presents with apnea or narcolepsy. It's very interesting because at the consultation we talked about, I don't treat that list of symptoms. I do treat underdeveloped jaws. So we're going to use expanders. We're going to develop the foundation. Then we're going to use aligners to coordinate your teeth and give you your bite back. And with all of that done, when we follow numbers and the math on what it is to have good jaw growth and development, you should have better breathing through your nose and better sleeping. But it remains to be seen how much healing we can have. She's got a wicked history for, age 3 to 14, just over a decade of suffering and seeing the medical community and, of course, being medicated in every one of those categories that you saw. The ultimate reveal was this senior year. At the end of her senior year, she comes in with her science study. And she participated in a research program for seniors in high school. And she built this whole experiment herself. She got a group of flies. That group of flies happens to be active during the day and dormant at night. So they kind of just freeze overnight. They stay still. So in a clear cylinder, you can see what the flies do all day long. They kind of have a rhythmic pattern to what they do. So the flies kind of cycle through the cylinder all day long in a very rhythmic and repeatable pattern. Okay. So now she documents all that. Then, of course, she's going to take the flies and split them in 2 groups. Now you have 2 groups of flies. And so the flies in one can basically are going to be that rhythmic moving during the day. And then at nighttime, they just kind of freeze and go to sleep. So it's dark and quiet. They go to bed. They don't move. The other canister, what she does with them is she wakes them up every 2 hours. So she goes, wakes that can up, lights on, shake the can, get them moving, and then lights off, let them go back to sleep. Now, every 2 hours she does that. Every 2 hours she does that. And 1 week later, within 1 week, that rhythmic pattern during the day is totally disrupted into chaos. So now, within 1 week of disturbing the flies every 2 hours, she has a canister of flies that are total chaos during the day, and then you document the difference, basically disrupting the sleep cycle. So if these flies ruins their daily activity, they cannot function. So she goes through sectional competition, takes first place, goes through regional competition, takes first place. For New York State seniors across all of the science submissions, she wins first place. So she is a first place winner for all seniors in high school for New York State research projects. And she's now second year college doing research. And second year college means that she is 4 years symptom free, 4 years asymptomatic, 4 years medication free. She only wears her clear retainer to bed every night, doesn't have a single symptom. And probably we don't expect her to have them at all, because you have proper breathing and proper sleeping with, all of that good balance. She shouldn't return to her symptoms at all, but we do have 4 years behind us now. So here we have a kid who's now second year in college looking to do research, and that's where she went, to a college where she could do research. And of course, her statement to us at the office was, in sharing this, I did to the flies what was happening to me. I couldn't sleep. I woke up every 2 hours. I couldn't breathe. I couldn't sleep, and it ruined me. I was unhealthy because of my sleep being destroyed. And you guys helped me to breathe better, sleep better. I'm a healthy human being now. So I wanted to prove that this is related. Don't be surprised one day we meet this kid doing significant research across sleep and breathing disorders. So what an opportunity to help a kid like that. And maybe she'll make an even bigger difference going forward.
Thank you, Ben. Great
all
lecture.
I have. Let me see if I can get my video.
Well, we
There
got a
you
bunch
go,
of
folks.
questions
A little
here.
bit of comprehensive care.
I got about 20 questions we're going to try to get through. Are you ready? You ready to take some questions?
I'm ready. Let's do it.
Okay. On your patient Lauren, when you expanded the arch, the palatal vault flattened. On your other patient Andrea, after widening the arch, the palatal vault was still V-shaped, meaning that the teeth moved, but the palate didn't expand. When you move the teeth that way, do you risk losing facial bone on the posterior teeth?
No, I have to go back into the question, because the question referenced and was stated as the teeth moving, but I showed you her numbers. She went from 30 to 40. We can't do a 10 millimeter expansion with teeth movement only. So I have to kind of back up and say the question isn't stated appropriately, in that the removable expanders in an adult grow the foundation. Now, maybe that person is seeing less change at the vault. However, that maxilla is bigger, because imagine the maxillary width stays the same and I move those teeth 10 millimeters wider. We're gonna have a big problem. So we don't do tooth movement there. We have to do foundational growth. So you
Right. So
witnessed
you're
10
having the
millimeters
alveolar bone
of
move,
change,
but not so
30 to
much the
40.
maxilla.
No,
Would
you'll
that
have sutural change. Yeah, you'll have sutural
You have
change.
suture. Okay.
Using removable expanders in an adult, you can have sutural change. Yeah, you have 6 decades to play with a suture mature before it's fully mature. In other words, yeah, when you're reading the bone dynamic textbooks and you learn about the maxillary suture, the maxillary sutures are not the same as the skull sutures. Your skull sutures go through full fusion. Your maxillary sutures never go through full fusion. They mature. So you have 6 decades. Now, removable expanders are slightly different than fixed, and the age is slightly different too. In an adult, you will have sutural changes, and you will have also maxillary growth, mandibular growth as well. But you're not going to see, like you saw in the fixed expander at age 14. That's a bit more of a difference in the maxillary suture. But to correct the question, that was not 10 millimeters of tooth movement. That was beautiful 6 to 7 millimeters of maxillary growth first, and then coordinating the teeth with another 3 to 4. That whole case is a 10 millimeter change, 30 to 40. Anyone moving teeth 10 millimeters apart and it's tooth movement only, they'll be out of the bone. The whole point was I can't do 10 millimeters with the clear aligners alone. So removable expanders for an adult is a very nice tedious cycle. The patient has to wear them for 2 hours, then remove them for 1. Wear them for 2 hours, then remove them for 1. You have to allow that bone to relax again. Cycling the pressure and tension gives you the bone growth you're looking for. And it's a non-surgical approach, which is very time consuming. It can take up to a year to do that. but it does give you the opportunity for maxillary and mandibular growth prior to your tooth movement.
When would you use the fixed expander versus the removable expander?
So I prefer to use fixed expanders all the way to 19. So if your age ends in teen, I love fixed expanders, but we use them with a very slow technique. So you can do, I use expanders slowly no matter when I'm using them, but in the younger kids from 8 to 12, you can do rapid. I don't do rapid anything. Everything we do is slow. So slow expansion at any age. And if it's 8 to 12 years old, I'm still using slow, but if it's 13 to 19, it's slower. So I do slow and slower expansion. Above 19, when you get to 20, I don't use fixed, I switch to removable. And the removable expanders can do wonders for patients looking to avoid surgical techniques. Yeah.
I've got a whole bunch of questions. When you started showing that first case, we got a whole bunch of questions about how do you, when you're doing expanders on provisionals, how do you keep the provisionals in the mouth? Keep the provisionals. And I know this was also asked to you at the aesthetic symposium.
Yeah. Yeah, it's a great question. And so, yes, when we place provisionals to go into aligners, we expect to be in aligners for 10 months or 12 months. So I do place my provisionals with permanent cement. So feel free to use a permanent cement, lock them on. You do want them locked on and you want them sealed. I wouldn't take the risk of temporary cement because using temporary cement doesn't mean they might loosen and fall off. They might just leak, and that's worse. If it falls off, you can clean the cement and put new cement. But if it doesn't fall off and it's leaking and you don't know it, there'll be a lot of decay under there. So I would not use a temporary cement. I do put permanent cement, and that's a very easy transition. We're restorative dentists, so we know how to take them off and transition to our finals. It's an easy step, don't worry. But permanent cement is the way to enjoy the clear aligners during those phases.
Do you normally do a CT scan before you start aligner therapy?
No, I don't normally do that.
Okay. As far as looking at the joints or anything?
No, I don't usually do that.
Okay, great.
If the patient has like an OSA diagnosis, we might get the CT scan for the airway imaging, like see how small is that space and what kind of difference we might make if we expand and align their teeth, give their tongue more room. But I don't usually take one. We do treat the symptoms because TMD is a list of symptoms. We don't treat that as a TMD treatment. We're treating it as a malocclusion condition, meaning they're trapped back. So I have underdeveloped jaws. I've got a trapped jaw. If they're narrow in back, you're probably going to have a percentage of your patients displaying TMD symptoms because of that. You may as well give them the freedom to have their bite come back together. And it turns out, while treating TMD symptomatic patients over the last decade, we don't really go back to night guards and splints afterwards. We just wear our clear aligners to bed. And I don't have patients pursuing TMD symptom treatment after clear aligner techniques that are wider and forward. Releasing the lower jaw is a really nice technique with clear aligners, and you can have a lot of symptoms kind of fade away.
Great. Here's a question: whether you ever see apical root resorption, that typical orthodontic blunting of the root tips. Do you see that with clear aligners?
No, the clear aligners aren't strong enough, and they're not strong enough to do that, and they're also not permanent. So brackets and wires are fixed, and because it's fixed, you have constant, 24/7, 365 wear. You have that constant pressure on the teeth, and it only takes a little threshold to start doing that. So you can have, root changes with brackets and wires, but you can't have them with clear aligners. And I say can't have them, but I can give you the scenario that you could, meaning you would make your patient wear them 24/7, 365, no break. If you keep your aligner in your mouth the entirety of every 24 hours straight through, you're approaching bracket and wire. Even then, they don't have enough strength. So to increase the strength of the aligner, you'd have to increase your speed. So the pathway to produce root changes with a clear aligner would have to be 24/7 wear, but you're going to wear them 1 week at a time, meaning the teeth struggle to keep up, and now you have forces increasing. It's almost impossible to have that scenario, which is why I say you can't cause damage to the gum and bone and roots with clear aligners, because you'd have to wear them 24/7, 365.
So you could get it, but you'd have to really work at it.
Yeah, you'd have to really, really work hard to cause damage with a clear aligner. It's near impossible.
Okay. And here's a question. Can these aligners correct posterior crossbite with an anterior open bite? And I'm assuming that's an adult they're talking about.
Probably an adult. Posterior crossbites are more challenging. So posterior crossbites are more challenging. I tend to go after the posterior crossbite with removable expanders first. So I like removable expanders first, and then once you get enough growth that you have no more crossbite, I switch them into clear aligners. Clear aligners are very capable at anterior open bite correction. So anterior open bite, when it comes to an anterior open bite, I prefer clear aligners over bracket and wire. They outperform them for that. So I use clear aligners for anterior open bite with a lot of success. The posterior crossbite, if you went at it with clear aligners alone, you would experience a level of success, but it's not going to be very high. So let's say you attempted 100 posterior crossbite corrections with clear aligners. You might get half of them. And that's not a bad average when you're trying to correct a posterior crossbite. But if you're looking for more success, you might want to think about removable expander first. And that kind of comes with learning how to do that.
Very good. Okay, what about retention? What is your instructions to your patients after you finish
Yeah.
active treatment?
Yeah, when we're done, we do get our retainers. So through the Glidewell clear aligners, they're called permaform retainers. They're clear, and basically you get a set of 4 of those. With that set of 4, they're built to last 1 year each, but we ask the patient to wear the first set 3 months full time. So the first retainer gets worn full time for 3 months, then they can start to wear it to bed only. It will still last a year. So you can have each of those retainers lasting you 1 year, but remember the first one should be worn full time to allow all of the histology to clear and to then have teeth that are solid, no longer orthodontically mobile.
Okay. And are there any patients that you would consider to be poor candidates for palatal expansion?
Above 70 years old is more difficult. And then, of course, I'm referring to non-surgical techniques. But you can have surgery at any age, really. You can have surgery at any age. It turns out, not a lot of patients are looking for surgery. And so in the non-surgical category, I don't usually go above 70 for palatal expansion. 60s and under, and it has to be much slower, even slower than, 30s, 40s, 50s.
Got it. Got it. Is there an optimum distance, palatal distance between number 3 and number 14 in adults?
Yes. Yeah. And there's a stack of research on this. Dr. James McNamara did a ton of research at the University of Michigan showing that children who develop good occlusions with minimal to no crowding have a measurement between 3 and 14 between 35 and 40. So 35 to 40 will give you 28 teeth where they belong really close, but it doesn't give you your wisdom teeth. So you're undersized for wisdom teeth, which accounts for the majority of kids needing their wisdom teeth out. So we know 35 to 40 is reasonable for 28 teeth to kind of fit in. Then you can look at even prior to him, which he did his research up to the age of 12, going back to Dr. Edward Bogue. Dr. Edward Bogue, whose research was 90 to 120 years ago, he did it in the primary dentition. Now, most people in dentistry quote Edward Bogue. They just don't remember his name or his numbers. But what they do is they look at baby teeth and they say, oh, you're 4-year-old, the baby teeth are all together. There's going to be big crowding coming. Because we know if you don't have spaces in your baby teeth, you got crowding coming. That's Dr. Bogue's research. But he gave it, not just that sentence, he gave it to us in measurements. And so it turns out Dr. Bogue was measuring the width. So he knew 2 things. You needed a significant gap between all the baby teeth for your permanent teeth to come in well. That significant gap by measurement is the thickness of a nickel. So it turns out if you can fit a nickel between all the baby teeth, you're going to have your permanent teeth come in nicely. But we don't see many children whose permanent teeth come in well. And we also don't see many kids who have baby teeth with a nickel between them all. So that's rare, meaning heavy crowding coming. Well, the measurement across the arch was 30 millimeters is the minimum. A to J need to be 30 at age 4 if you're going to have minimal to no crowding. So under 30 at age 4 between A and J, here comes your crowding. Now, 4 years old, 30, 8 years old, 35, 12, 40. These are good numbers because the last piece of the puzzle is anthropology research, which shows a few hundred years ago when humans all developed full jaws and 32 teeth where they belong, the minimum distance between 3 and 14 is 50 millimeters.
Wow.
50. So I've had the pleasure of spending time with 2 malocclusion anthropologists, Dr. Robert Corcini and Dr. Jerome Rose, asking them directly, what's the smallest transverse measurement either of you have come across in your combined 100 years of research? And they said, I've never seen a number less than 50 in the human race prior to the early soft food. And the average, you ready for the average? The average width of a human when the jaws grew fully, 55. So I bring them to 40. I bring them to 40 because you start breathing.
What do you think the average width is today?
Oh, the average width today is probably low 30s.
Yep.
We have early soft food, weaker muscles, smaller jaws. and crowded teeth. It's kind of a self-inflicted wound. But basically, yeah, the early soft food is the transition from well-developed jaws to poorly developed jaws. Baby
Absolutely
food.
fascinating. Dr. Ben Miraglia, thank you for a great lecture and really, really instructive cases. We enjoyed seeing it. Thank you for answering all those questions too. Thanks to our panel and thanks to all of you for joining us today. We're going to be off next week for the Labor Day weekend, but we'll be back in 2 weeks with the return of Dr. Randy Resnick to continue his series on occlusion for implant restorations. So we'll see you back here in 2 weeks at the same time. We'll see you then. Have a great Labor Day holiday. And thank you again, Dr. Ben Miraglia. Take care.
Thank you
My
so
pleasure.
much.
Thank you.